everyone. Thank you for the opportunity to present my fellows' research in this forum. I have no conflicts of interest to disclose. There are two common testing methodologies used to diagnose pertussis infection. One, the dedicated pertussis PCR, which identifies both Bordetella pertussis as well as parapertussis. And two, the comprehensive respiratory pathogen panel, or RPAN, which identifies multiple viral and bacterial targets, including Bordetella pertussis. So which test should you choose? Anecdotally, many clinicians choose the RPAN rather than pertussis PCR testing to diagnose pertussis. But first, let's look at the literature. While not common knowledge, Jarris et al. In 2015 compared these two testing methodologies and determined that the dedicated pertussis PCR test identifies up to a third more cases of pertussis than RPAN testing. However, this particular study was limited to the pediatric population and did not look at other pathogens identifiable on RPAN. In addition to that, many studies have documented a high rate of co-infection with other pathogens during pertussis, and other studies have found a high rate of viral detection in asymptomatic individuals. Specifically, a viral surveillance study out of Utah in 2015 found that up to 44% of the time a virus was detected, the patients were actually asymptomatic. So therefore, if we use RPAN testing rather than pertussis PCR testing to identify pertussis infection, we are at risk of incorrectly attributing a patient's symptoms to a virus rather than pertussis. Therefore, the objectives of my study were to, 1, determine the number of cases of pertussis missed on RPAN, 2, determine the rate of co-infection in pertussis cases missed on RPAN, and 3, determine the rate of co-infection in all pertussis PCR positive patients. The microbiology laboratory at the University of Michigan performed comprehensive respiratory pathogen panel testing on all of the pertussis PCR positive patients from March of 2015 to October of 2017, which included the inpatient, outpatient, and emergency medicine settings. Then, the rate of pertussis identification on RPAN was determined, and then we tabulated the presence of additional specific pathogens, and finally, descriptive statistics were used to analyze the demographic and clinical information. Approximately 3,500 patients were tested for pertussis between March of 2015 and October of 2017. Of those, 137 patients were positive for pertussis, and this is approximately 4% of samples. Of the positive pertussis PCR samples, 102 were saved and available for testing, and this was the cohort used in my study. The ages of patients with pertussis infection range from 1 month to 73 years of age, with a median age of 10 years. We are identifying pertussis in both children and adults, so it's important for all of the clinicians in the room to keep it on their differential. At U of M, pertussis identification occurred predominantly in ambulatory clinics. And additionally, it is known that pertussis infection does not have a seasonal predominance, and as you can see in this cohort, we are identifying it year-round. So on to results. So of the total 102 banked pertussis PCR samples, all of those were tested by RPAN. Of those, the RPAN was negative for pertussis in 44% of cases. These are the potential missed pertussis cases if RPAN is used alone for diagnosis. More importantly, the RPAN was negative for pertussis but positive for other pathogens in 44% of those samples. And this can lead to potential missed diagnosis. Specifically, the pathogens found on RPAN in this group were adenovirus, coronavirus, human metapneumovirus, parainfluenza virus, rhinoenero, and RSV. So a big number of different viruses. But what about the rate of co-infection in all of the pertussis PCR positive patients? In the following slides, we will look at the specific RPAN results for the entire cohort of dedicated pertussis PCR positive patients. The RPAN pertussis positive patients will be represented in yellow, and the RPAN pertussis negative patients will be represented in gray. This heat map displays the RPAN results of all pertussis PCR positive patients, and each row represents an individual patient. The first column demonstrates the RPAN results for pertussis. The yellow shading indicates the 56% of patients that were also positive for pertussis on RPAN, while the gray shading indicates the 44% of patients for RPAN testing was negative, the potential missed cases of pertussis. Looking across each row, you can see the additional pathogens identified in black. The most common additional pathogen identified was rhinoenterovirus at 24%. Interestingly, the distribution of additional pathogens identified by RPAN was actually similar between the RPAN positive and RPAN negative pertussis patients. And statistically speaking, testing positive for other pathogens on RPAN was equally likely among these two groups. With this information in mind, should we really be using RPAN to diagnose pertussis? I would say no. As we saw, the RPAN only identifies a proportion of pertussis infections, and in this cohort, RPAN really did no better than a coin flip. Furthermore, the presence of other pathogens cannot be used to exclude pertussis, and there was no statistically significant difference in the rate of additional pathogen detection between those RPAN positive and RPAN negative pertussis groups. Those additional infections might represent co-infection, and they might represent asymptomatic viral carriage, but it's impossible to differentiate between those two. Therefore, if RPAN is used for pertussis diagnosis rather than dedicated pertussis PCR, there's a risk of incorrectly attributing a patient's illness to another pathogen. And this has serious public health implications given the communicability of illness, decreased vaccination rates, decreased herd immunity, and the morbidity and mortality, especially in the youngest patients. There were a few limitations to my study. For one, detailed medical records were not available for half of the patients because those particular patients were tested in ambulatory clinics and did not have a MyChart record. Additionally, delayed reanalysis of samples may affect RPAN test results. However, DNA should not significantly degrade over time, and validation testing through repeat dedicated pertussis PCR is being completed. Among the 10% of samples that have been already retested, there does not appear to be a significant degradation, but validation of those remaining samples is still underway. So the bottom line, if you're concerned about pertussis infection, use the dedicated pertussis PCR. And to only use RPAN if identification of other specific targets will change your clinical management, such as mycoplasma or influenza, since all others do not have a specific treatment. So as a trainee, I've been thinking about the possible next steps of this research. One direction is a quality improvement initiative to impact clinicians' testing practices, including a survey of clinicians on their testing practices and then PDSA cycles to affect clinical decision-making. Other interesting next steps would include a cost analysis of these two different testing methodologies, as well as, ideally, a prospective study. Questions?
So given that level of performance, not only should people not use it, FDA should remove the pertussis part from the market, I would think. And I guess it makes me wonder if the pertussis part of the RPAN works that well, how well the other elements work against their various gold standards, and whether the RPAN should just be removed from practice altogether.
It is an interesting question. If you work with me on shift, I might tell you that. But to help answer that question a little bit more, I do think more prospective studies will be needed that have both the dedicated pertussis PCR as well as the RPAN sent at the same time, so there wouldn't be the concern for degradation.
And
Do you think that a selection of which could be used is being motivated by cost? Do providers know how much each of those tests cost?
So currently in our medical record, we do not have the little dollar signs that I know they have in some medical records to indicate the difference in cost. Specifically at the University of Michigan, I do have information on cost to patient available. So this is the cost that U of M would charge the out-of-pocket patients, and the dedicated pertussis PCR is significantly cheaper than the RPAN.
So it's cheaper and better.
Cheaper and better. Dr. Zink?
Yeah, I should know this, but can you be a asymptomatic carrier of pertussis? Because that might be a confounder here. If
That's
true. I don't think it is, but what's your experience with that?
That's another good question. The research that's available in the literature talks more about the duration of time that your pertussis PCR should be positive, and that is only early on in the illness. So on the other hand, another concern would be that patients actually do have pertussis, but we're not picking them up. So unfortunately, I don't know the answer to your question, but pertussis PCR has its optimal sensitivity during the first 3 weeks after cough onset. And so if we're thinking about it later on during their 100-day cough, we could even be missing it. Thank you.